Imagine, walking into a doctor's office because you need surgery. You're sitting on that crinkly paper covering a cold exam table, feeling just incredibly vulnerable.
Right. It is not a comfortable place to be.
No, not at all. And the doctor recommends this highly effective, quote-unquote, gold standard medical device to solve your problem. But as soon as they say the name of the procedure, your stomach just drops.
Because you recognize it.
Exactly, because it's the exact same medical device you've seen at the center of those terrifying multi-million-dollar lawsuit commercials on late-night TV. Like, do you say yes, or do you
Yes.
just run for the door?
It is a really profound dilemma. I mean, the traditional power dynamic in a doctor's office is already heavily weighted to one side.
Oh, for sure, you're in their territory.
Right. But when you add massive media confusion and fear into the mix, patients often just freeze. They either blindly agree to a procedure they are terrified of, or they walk away from a treatment that could really radically improve their quality of life.
Okay, let's unpack this, because that exact scenario is happening every single day to women suffering from stress urinary incontinence.
Yes, every single day.
And today's deep dive is designed specifically for anyone navigating this exact maze. We are taking a stack of medical guidelines, FDA statements, and patient advocacy resources and distilling them into a really practical, empowering toolkit.
The mission today is highly focused. We are going to build a specific, actionable framework of questions a patient absolutely must ask their surgeon regarding the safety and the experience of getting a mid-urethral mesh sling.
Which sounds complicated, but we'll break it down.
Exactly. The goal is to arm you with the right questions so you can shift that power dynamic in the exam room, cut through the noise, and make a decision based on your unique biology, not late-night television.
I love that. So to equip you with those questions, we first have to understand the mechanics of what this device actually does.
Right, the basics.
Yeah, and more importantly, we have to look at why the word mesh immediately raises so many red flags. Let's start with the condition itself. Stress urinary incontinence, or SUI.
Yeah.
How is it physically different from just, having a sudden urge to go to the bathroom?
Well, stress urinary incontinence is entirely mechanical. It actually affects up to 1 in 3 women.
Wait, 1 in 3? That is huge.
It's incredibly common. It's the involuntary leakage of urine during moments of physical stress. So when you cough, laugh, sneeze, jump, or even just pick up a heavy bag of groceries, the pressure inside your abdomen spikes.
And normally your body can just handle that pressure spike, right?
Right. Normally, the pelvic floor muscles and the connective tissue supporting the urethra, which is the tube that carries urine out of the body, they act like a firm backstop.
Okay.
So when the pressure hits, the urethra is squeezed shut against that firm support. But with SUI, that anatomical support has weakened, often due to childbirth, aging, or genetics.
I see.
So when the pressure spikes, the urethra drops or it becomes hypermobile and it doesn't close properly, fluid escapes.
So the structural support is basically just gone, which is where the mid-urethral sling, or MUS, comes in.
Exactly.
And looking at the sources, this was introduced in Europe in the 1990s and approved by the FDA in 1998. It's a minimally invasive surgery, but, and I think this is where the confusion starts, when people hear mesh sling, I think they picture this large, hammock-like piece of fabric.
They absolutely do.
The medical terminology calls it a strip of macroporous knitted monofilament polypropylene. Let's translate that for everyone. What does that actually look like in plain English?
It is remarkably small. I mean, it is a strip roughly 1 centimeter wide.
1 centimeter. That is less than half an inch.
It's tiny. Now, the material itself, polypropylene, is really just a type of plastic. But the way it is manufactured is the key to how it works inside the human body. You mentioned macroporous.
Right.
That means the holes in the mesh weave are relatively large.
Wait, why would we want large holes in a medical implant? Doesn't that make it weaker?
No, actually, because you don't want the body to wall it off like a foreign object. You want the body to accept it. Those large pores act like a trellis in a garden.
Oh, a trellis. Okay.
Yeah, over the course of 4 to 6 weeks, your body's own cells, blood vessels, and collagen actually grow through those holes, the tissue vines around the plastic trellis, anchoring it permanently into your anatomy. It literally becomes part of you.
Oh, wow. That's kind of amazing. And what about the monofilament part? What does that mean?
Well, think of the difference between a single solid piece of fishing line versus a braided rope.
Okay, yeah.
A braided rope has thousands of tiny microscopic crevices between all the threads. In the human body, those tiny crevices can become hiding places for bacteria.
Oh, yikes. which leads to infection.
Exactly, chronic infections.
Yeah.
A monofilament like that single strand of fishing line doesn't have those hiding spots. It
Oh,
significantly lowers the infection risk.
I see. And this polypropylene material, it isn't a new invention, is it? We aren't testing some experimental plastic on people.
Not at all. Polypropylene is a standard surgical material used safely across almost every specialty for over 50 years.
50 years.
Yes. If you or someone you know has ever had a hernia repaired, chances are very high they have polypropylene mesh inside them right now.
Wow. Okay.
For incontinence, this tiny strip just acts as a dynamic support. It sits loosely under the urethra, and when you cough or laugh, the urethra finally has a firm backstop to compress against again. No more leaks.
Wait, let me stop you there. If this is a 50-year-old material,
Right.
and the design is this tiny, minimally invasive strip that allows your own tissue to grow into it safely, why did it trigger a massive wave of lawsuits? How did a 1-centimeter strip of plastic become public enemy number one?
This is the critical distinction every single patient must understand. The FDA issued serious warnings, and there were massive, highly publicized lawsuits regarding transvaginal mesh used to repair a completely different condition called pelvic organ prolapse, or POP.
Okay, prolapse being when the pelvic organs, like the bladder or the uterus, actually drop out of their normal position.
Exactly. It's a much larger structural issue. So to physically hold back those falling organs, surgeons were using massive sheets of mesh.
Ah, so not a tiny strip.
No, we are talking about a huge footprint of material placed in a completely different anatomical plane and subjected to constant, heavy downward pressure from the organs.
That sounds like a recipe for disaster.
It was. Under that constant stress, those large sheets of mesh could fold, bunch up, and actually erode through the vaginal wall. It caused severe, devastating complications.
So the prolapse mesh failed because it was just too much material under too much pressure in the wrong place.
Precisely. But the mid-urethral sling for incontinence is tiny, it's placed in a totally different area, and is under almost no constant pressure. It just sits there waiting for you to cough.
Right.
The FDA considers the mid-urethral sling for SUI to be incredibly safe and effective. In fact, clinical data spanning up to 17 years shows excellent long-term durability.
That's reassuring.
And here is the kicker. There has never been an FDA recall for mid-urethral slings. Not once.
That is wild. So basically, because the word mesh was used in both the prolapse procedure and the incontinence procedure, the media narrative just conflated the two.
Yes, exactly.
It's like hearing a safety recall about a faulty engine in a heavy-duty truck, and suddenly people are terrified to use the seatbelts in a completely different compact car. We need to make sure we're actually evaluating the right part.
That is a perfect analogy. And if we connect this to the bigger picture, that conflation created a massive wave of anxiety. Patients are walking into clinics absolutely terrified, holding on to a mix of facts and misinformation.
Yeah, you can't blame them for being scared.
Not at all. And that perfectly sets the stage for our toolkit. You need facts to cut through the fear.
Okay, let's get into the toolkit. The questions. Because before you even agree to let someone operate on you, you need to explore the landscape of options. Where does a patient even begin this conversation?
You start by forcing a discussion on the least invasive options. You look your surgeon in the eye and ask, have I tried all the non-surgical options available to me?
Like what? What are the non-surgical options?
This includes things like intensive pelvic floor physical therapy, lifestyle modifications, or vaginal inserts called pessaries. You want the doctor to explicitly justify why they believe non-surgical treatment won't be enough to manage your specific severity of leakage.
But let's say you've done the physical therapy for 6 months. You've cut out caffeine, you've done the work, and the leakage is still just ruining your quality of life. The conversation naturally turns to surgery.
Right. At that point, you ask about the surgical alternatives. You say, why are you recommending a synthetic mesh procedure for me instead of non-mesh alternatives?
Now let me challenge that for a second. If the mesh sling is the undisputed gold standard according to urological societies, and we just established it's safe, why would a patient ever bother asking about non-mesh alternatives? Isn't that just adding unnecessary confusion?
It is never unnecessary, because true informed consent requires understanding what you are saying no to just as much as what you are saying yes to.
Okay, fair point.
And non-mesh alternatives do exist. A surgeon can create a sling using donor tissue from a tissue bank, or they can perform what's called an autologous fascial sling.
Autologous meaning from your own body.
Right.
What exactly are they taking?
They harvest your own fascia. Fascia is the incredibly tough, fibrous casing that surrounds your muscles. They usually take it from your abdominal wall or your thigh.
Wait, but to get that tissue, they have to make a completely separate, significant incision on your body.
Exactly. And this is why you must ask the question. You need to hear the surgeon verbally weigh the biological trade-offs out loud.
Right, because that sounds like a much bigger deal.
It is. Harvesting your own tough connective tissue creates a weak spot in your body. It introduces new risks wound infections at the harvest site, or a seroma, which is a pocket of clear fluid that builds up in the empty space where the tissue used to be. You even run the risk of developing a hernia at the harvest site because the structural wall is compromised.
Wow. So it's basically a choice between the low but real risk of a synthetic implant versus the guaranteed longer recovery and physical trauma of harvesting your own body parts.
Precisely. You need to decide which set of risks you are more comfortable living with.
Okay, let's say you weigh those options and decide the synthetic mesh is the right path. The next variable isn't the device itself, it's how it gets put inside you. Looking at the medical guidelines, there are different ways to route this 1 centimeter hammock.
Yes, there are primarily two surgical approaches, retropubic and transobturator. You need to ask your surgeon, what are the pros and cons of these different methods for my specific anatomy?
How different can they be?
Anatomically very different. The retropubic approach involves passing the sling up behind the pubic bone to exit through two tiny incisions just above the pubic hairline.
Okay.
But because the surgeon is passing needles blindly past the bladder, there is a higher risk of accidentally perforating the bladder.
Oh, ouch. That sounds awful.
In fact, they routinely use a tiny camera called a cystoscope to look inside your bladder during the surgery just to make sure they didn't poke a hole in it.
That sounds intense. What about the other option?
The transobturator approach avoids the bladder entirely. Instead, the sling is routed laterally out through the inner thigh or groin muscles.
Oh, okay. So no bladder risk.
The risk of bladder injury drops significantly, yes. But passing through those groin muscles introduces a new risk chronic post-operative leg or groin pain.
This is fascinating.
Mm-hmm.
You are literally choosing which anatomical neighborhood you want to disrupt.
Exactly.
And that brings up personal risk factors too. You must ask, is my individual risk different from the standard? I mean, if a patient has severe allergies or an autoimmune disease where their body aggressively attacks foreign substances, putting a permanent synthetic trellis in their pelvis seems like a really crucial thing to discuss.
Absolutely. The standard safety data applies to the general population, but your doctor needs to tailor that data to your specific medical history.
Okay, so you've evaluated the device, the alternatives, and the anatomical routing. You and your doctor agree this is the path. Now we move to the next phase of questioning. You have to vet the person holding the scalpel.
This is critical. You are hiring a professional for a highly specialized job. You need to verify their specific expertise.
It's like taking your car to a mechanic. If your transmission is failing, you don't just ask if they've read the general manual on cars. You ask how many of this specific transmission they have rebuilt this year.
Right.
You don't want the guy who mostly does oil changes taking apart your gearbox. What is the magic number for a surgeon doing a mid-urethral sling?
You must ask them directly. How many of these specific mid-urethral sling surgeries do you perform yearly? The guidance from NICE, the National Institute for Health and Care Excellence, recommends that patients look for a surgeon performing at least 20 to 25 of these procedures annually.
20 to 25 a year. So that breaks down to roughly 2 a month.
Yes. That is the threshold to feel comfortable that the surgeon is maintaining the muscle memory and the high skill level required to navigate that complex pelvic anatomy safely.
Makes sense.
If a surgeon says they do 3 or 4 a year, they are simply not getting the reps in.
And it's not just volume, right?
Yeah.
It's the quality of the work. You have to ask, what are your personal success and complication rates?
Correct. Do not let them just quote the national average from a medical journal. The national average doesn't operate on you.
Such a good point.
You want to know the specific outcomes of the patients they have personally had on their operating table.
Here's where it gets really interesting, and honestly, this requires a bit of bravery from the patient. You are advised to dig into the surgeon's industry influences.
Yes, you should certainly ask if they are explicitly credentialed by their hospital for this exact procedure. But the empowerment goes further. You have the right to ask, do you receive payments, consulting fees, or other financial benefits from the manufacturer of this synthetic mesh?
Wow. Looking a doctor in the eye and asking if they are on the payroll of the company whose plastic they're about to put inside you. That is a heavy, heavy question.
It is, but it's important.
And you also need to ask, will representatives from the mesh company be in the operating room during my surgery?
Right. It can feel confrontational, but this is about understanding the modern medical environment. Device representatives are frequently present in operating rooms.
Wait, really?
Hmm.
Just hanging out in the OR?
Well, they are there to provide technical support regarding their specific instruments or implants. But as a patient, you have a fundamental right to know who will be standing in the room while you are unconscious and whether there are any financial incentives subtly influencing the choice of device.
I feel like I'd be sweating just asking it. How is a surgeon actually going to react to that level of interrogation?
Honestly, a confident, highly experienced, and ethical surgeon will not flinch. They will welcome these questions because they are accustomed to transparent discussions about informed consent.
Okay, that's good to hear.
However, if a surgeon becomes defensive, dismissive, or acts offended that you dare to question their volume or financial ties, that is a massive flashing red flag.
Time to run for the door.
Exactly. If they cannot handle your self-advocacy before the surgery, they're likely not the right partner for you if something goes wrong after.
Which brings us to the final and perhaps most vital phase of questioning, preparing for the what-ifs. Because even with a surgeon who does 100 of these a year, no medical procedure is 100% risk-free.
Exactly. You must boldly address what happens if things do not go as planned. You need to ask, what specific known risks and side effects should I be looking out for?
So what are the complications unique to this mesh?
Well, while the complication rate for the mid-urethral sling is genuinely low, the most common mesh-specific issue is called mesh exposure.
What does that mean?
This occurs when the tissue healing process fails slightly and the mesh actually becomes visible through the lining of the vagina. The average rate for this is about 2% at 1 year.
What does that actually mean for the patient physically? Does it hurt?
It can. It can cause a scratching sensation, chronic pelvic pain, or pain during sexual intercourse for both the patient and their partner.
Oh, that sounds awful.
You also need to ask your surgeon about the risk of the mesh eroding into the bladder or urethra, and the risk of developing difficulty urinating because the sling is pulled too tight.
You really have to demand specifics. Don't just wait until you're recovering at home, feeling a sharp pain, and wondering if it's normal healing or a massive complication.
Exactly. And then you must ask the hardest question of the entire consultation. If I have a complication, do you personally know how to fix it, or will you need to refer me to a specialist?
Wait, if the complication rate is only 2%, why are we dedicating such intense focus on how to fix it? Can they just take the mesh out?
This is where the biology of the device works against you if things go wrong. Remember the trellis analogy.
Yeah, the cells growing into the holes.
Right. Your body's cells, blood vessels, and collagen have grown entirely through those large pores. It integrates completely.
So it's stuck.
Trying to remove it is like pouring concrete over a chain link fence, letting it set for a year, and then trying to pull the fence out.
Oh my God.
You can't just slide it out. You have to chip away the concrete. Removing a permanent mesh implant is incredibly difficult.
I can imagine.
It requires specialized surgical skill to carve the mesh out without destroying the healthy tissue around it. Attempting removal can cause further injury to the urethra or bladder, and it almost always results in a complete return of the original incontinence.
That concrete analogy is terrifying, but it makes the reality so clear. You need to know if the surgeon putting the chain link fence in has the advanced skills to chip the concrete away if they have to.
Yes.
You need the contingency plan before you go under anesthesia.
And you also need the physical documentation of the contingency plan. Ask your surgeon, can I have the patient information brochure, the exact brand name, and the product barcode for my personal records? Keep a physical file.
Wait, why the barcode? Like on a grocery item?
Yes, because 20 years from now, you might move across the country. Your original surgeon might retire. If there is ever new medical guidance regarding that specific device, or if you develop an issue decades down the line, a new doctor needs to know exactly what is embedded in your tissue. The barcode tells them everything.
So what does this all mean? We've just outlined an incredibly intense, highly technical interrogation. We are asking patients to discuss autologous fascia harvests, transobturator routing, and device representative finances. How is a patient supposed to manage this while wearing a paper gown?
What's fascinating here is that the medical community recognizes this overwhelming burden on the patient. Major medical organizations like the American Urogynecologic Society and the Society of Urodynamics are now heavily championing the use of formal patient checklists.
Like an actual physical piece of paper you bring to the appointment.
Yes. A printed checklist isn't just a defensive legal tool for the hospital, it is a vital communication bridge. It forcibly disrupts the power dynamic.
How
When a doctor has to physically stop their routine and check off a box confirming they discussed alternative tissue harvests and mesh exposure rates, it slows the conversation down. It ensures the patient genuinely understands the complex biological risk and reward math of the surgery.
It forces a pause. Okay, let's recap this toolkit.
Yeah.
We started by demystifying the mid-urethral sling. We learned that it is a tiny 1 centimeter trellis designed to let your own tissue grow into it, acting as a backstop for your urethra.
Right.
And we learned why it is completely distinct from the large, heavy sheets of transvaginal mesh used for prolapse that failed under pressure and caused all the media panic.
Exactly. Once the fear is replaced with facts, we organized your consultation into 3 actionable phases. First, evaluating alternatives, including the risks of harvesting your own tissue, and discussing anatomical routing to ensure this path is right for you.
Yeah.
Second, vetting the surgeon's experience, demanding they meet that minimum volume of 20 to 25 surgeries a year, and asking hard questions about their financial ties.
And third, preparing for the what-ifs. Understanding mesh exposure, the extreme difficulty of removing the device once the tissue integrates, and demanding a clear plan for complications. The ultimate goal here is transformation.
Absolutely.
We want to take you from being that passive bystander, just nodding along to medical jargon, and turn you into an active, fierce, and informed partner in your own health journey.
It is your pelvic floor, your quality of life, and ultimately your decision to make.
We know from high-stakes environments like commercial aviation, nuclear power, and even surgical operating rooms themselves, that checklists save lives by preventing human error. They enforce a mandatory pause. But building on what we've explored today about the immense power of patient-led questioning, it really makes you wonder,
I know it.
why aren't standardized, mandatory patient interview checklists required by law before any elective surgery can take place? Imagine a world where, by law, a surgeon couldn't even book an operating room until both of you signed a document proving they had answered these specific, uncomfortable questions. It's a paradigm shift to think about the next time you, or someone you love, steps into a clinic and tries to navigate the deep waters of modern medicine.